Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I am the chair-elect of BTOG. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It is important to say that sponsors of BTOG do not have any role whatsoever in the planning, delivery, content of anything discussed today. Hello and welcome to another BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea Westminster in London. I'm also the chair-elect of BTOG. I'm joined rather unusually for this podcast by two colleagues. I am outnumbered 2-1 by my clinical oncology friends. And we've titled this podcast Stage 3 Non-Small Cell Lung Cancer, an ESTRO Update. And the reason for that is there's been a recent meeting, ESTRO, of which one of the major focuses from a lung perspective was stage 3 disease. And I thought it was a great opportunity to update ourselves on this really fluid area and quite complex area. So I'm joined, as I say, by two colleagues. I'm joined by Corinne Faivre-Finn, who is the Professor of Thoracic Radiation Oncology at the Christie. Before the podcast, I tried to go through Corinne's CV, and it was so long that if I went through everything she did, we'd basically be here for the whole podcast. I'm not going to do that, but she does do lots and lots of important things. She's a radiation lead for the Manchester Cancer Research Centre and is also one of the main leads on the excellent Concord study. I'm also joined by Fiona McDonald, who is a clinical oncologist as well at the Royal Marsden Hospital, who has an equally impressive CV. Fiona has two attributes, one of which is that she runs a number of studies, including the excellent HALT study we're looking forward to seeing the results of. And she also has the pleasure of being able to look after my patients as well in our joint MDT. So having flattered these two people, we're now going to move on to the meat of the situation, and we're going to talk about stage 3 disease. But before we do that, I'm going to ask Corinne just to tell people a little bit about ESTRO, who may not know where it was and what kind of meeting it is. Corinne, over to you.
Well, it's a pleasure to join you for this podcast, Tom. So ESTRO is the European Society for Radiotherapy and Oncology. And it includes a number of professionals who work in the field of radiotherapy, so radiation or clinical oncologists, physicists, radiographers, or so-called RTTs in Europe, biologists, and of other specialties as well that contribute to the field. So it's a very multidisciplinary group. We do, of course, always welcome medical oncologists to ESTRO, and of course, much of a discussion nowadays is about the optimal combination of radiotherapy with systemic therapy.
And it was in Glasgow, I think, over the bank holiday weekend. How many people turn up to this kind of meeting? Is this a huge event?
It was a huge amount. So it was probably
7,000.
Yes, 7,000.
7,000.
Wow. And this is obviously all radiation oncology, not just lung. But if I'm right in saying one of the main focuses from the lung point of view was stage 3 disease. So if you give us, Corinne, just maybe a snapshot, what maybe have we learned most about stage 3 disease from what you heard earlier this month?
Yeah, so there were two sort of main focus for the discussions we had at ESTRO. So one was very much around the evolving role of neoadjuvant chemo IO prior to surgery, and where does radiotherapy fit in this new treatment paradigm. And then the other one was around the combination of radiotherapy with systemic therapy, but also whether we should very much think about de-escalation of radiotherapy as opposed to escalation of radiotherapy, which had been the focus of much of the research in the last 2 decades. Okay.
Fiona, can you remind me about the escalation of radiotherapy? Because I remember going to meetings, I think one of them was in Sydney, and there were studies about escalation of radiation dose. For those like me who are not familiar with this field, could you just remind us where we'd got to maybe up until 2-3 years ago?
So, I mean, as Corinne says, that one of the main focuses was dose escalation when I was training and when I was a young consultant, and dose intensification. But the big shock came, gosh, was it 20,
2013.
2011, 2013.
2013 presented at Astro.
Thank you. So that was RTOG 0617, which was the big shock that escalating everybody to 74 Gray in 2 Gray per fraction rather than 60 Gray in 2 Gray per fraction. Not only was not beneficial, but there was more higher death rate in those treated to the higher dose.
Okay.
So we know that simply taking everybody in a one-size-fits-all approach and extending out the treatment course is not the way to go. So there's been various other studies done since then, whether it's using kind of what we call dose painting, using PET information, or isotoxic escalation, which is where you give everybody a different dose within their dose constraints. Number of other strategies, but essentially all of them looking at increasing the dose or dose intensification. And now with the newer systemic therapies, particularly with immunotherapy, we're starting to question whether we need to escalate it at all, or whether actually there is a potential advantage by reducing the dose, or maybe reducing the dose, for example, to lymph nodes and maintaining dose, let's say, to the primary. So a whole host of new questions now the systemic therapy paradigm's changed.
Okay, that's really helpful. So Corinne, how might we now de-escalate? What evidence do we have that that's a safe thing to do, or do we not have evidence? And actually now we need to be designing the studies to answer that question.
Yeah, so we do not yet have evidence that that's what we should do. I mean, what we've learned over the last few years is that certainly we should not give any radiotherapy to the non-involved nodes. So there was an excellent study done by Ursula Nesle in Germany called PET-Plan, that compared the so-called elective nodal irradiation to just radiotherapy guided by the information from a PET scan and the EBUS. And we've learned that that is absolutely fine to just include the involved nodes.
And that would be, sorry to interrupt you, that would be, they're not involved because they're PET negative, or have you also done EBUS to confirm?
Well, that's a good question, Tom.
Yes.
Well, that's why I get paid the big bucks.
Absolutely. So no, they were not always EBUS confirmed. So it was mostly in that particular study, the radiotherapy was very much guided by the information from a PET CT.
Right. So, okay, great. So we know that. What other evidence do we have that we could de-escalate? So
without going into too much sort of radiotherapy details, but the when we plan radiotherapy, so we outline the primary tumor and the lymph nodes, and then we create a margin around that called the CTV, or the clinical target volume, to take into account the microscopic extension around the tumor. And there is now a debate as to whether we should get rid of that margin in the era of modern radiotherapy, and that would help reducing the volume of disease. And it's really important to reduce the volume of disease, because we've also learned in the last few years that we should decrease the dose that we are delivering, particularly to the heart, but also to the blood pool, in order to reduce the risk of lymphopenia. So we know that lymphopenia post-chemoradiotherapy, which can be not only profound but also prolonged, is a very poor prognostic factor. So we know a lot more about that. And there's now some, we're now discussing whether not only we could decrease the dose that we are traditionally giving. So, at the moment, one of the standard dose we're delivering in the UK in the context of concurrent chemoradiotherapy is around 60 Gray, or if people give hypofractionated radiotherapy, 55 Gray in 20 fractions. So whether we could decrease the dose to the volume that we're treating, but perhaps could we completely omit radiotherapy, even to the involved nodes, in the era of combination with immunotherapy? So that's very provocative. I think the studies would be very difficult to do. Some people would probably question, whether that is ethically right to do. But these are questions that are, have been put forward.
And we also have some hints from other studies, don't we? So we know from, for example, Checkmate 816, with these drugs, we are starting to see path CR. So if it's doing that in surgical patient, what's it doing in a more locally advanced scenario? And you could imagine that maybe some of the involved lymph nodes, even if the primary doesn't get a path CR, you could imagine some of the smaller lymph nodes maybe are, and that's why it's worth exploring. So not only reducing the volumes, i.e. getting rid of CTV margins, but maybe you can reduce, the margins and not include all of the original nodes if you restage. These are all kind of open questions. And as Corinne says, if you look at the lung art, when post-operatively lung art trial, when we were giving radiation, we know that although the radiation increased local control, there was a detriment to cardiac deaths. So that's another reason to revisit it.
So are these questions being driven by changes in systemic therapy, or are they being driven by changes in radiation oncology techniques? Because Corinne, you talked about as radiation evolves, we're asking these things. What's changing technology that would allow us now to change dose, change field, or is it purely the arrival of immunotherapy and neoadjuvant treatments that's driving that?
It's a bit of both. So on one hand, we're hoping that adding better systemic therapy, for example, immunotherapy, may allow us perhaps to treat either with lower doses or smaller volumes of disease. But also we have obviously better, more advanced radiotherapy techniques that can allow us to reduce those to specific organs at risk or regions within organs at risk. And we talked about the heart already. And, for example, protons may be a technology that could be applied to help us reduce the dose to critical organs, but also protons can reduce what we call the integral dose that is delivered, which will have a huge benefit in terms of potentially reducing the risk of severe lymphopenia.
Okay.
There's also stereotactic radiotherapy that we know has done, got really good results and really well tolerated in early stage disease, even in frail patients. And one of the American strategies in studies at the moment is to actually use stereotactic techniques and doses to the primary and maintain a more conventional approach to the lymph nodes, so splitting it in sort of two. And the phase 2 of that was presented at ASTRO last year in September. And the phase 3 is ongoing. It's one of the LU00s. I want to say LU005, I think, is the study ongoing. Yeah, so that may be a way we go, regardless of whether we reduce the dose to the nodes. It may be that we should be really focusing on the primary and looking at dose de-escalation maybe only to the nodes.
So one of the questions which I think we're all facing in our MDTs now is the Checkmate 816 question. We're sitting in our MDTs, people are coming through with potentially resectable disease. MDTs are beginning, I hope, to have patients coming through. Fiona, certainly you and I have had several patients coming through who we feel are resectable. They've gone down a neoadjuvant chemoimmunotherapy approach. What does this regimen, and maybe Fia, I'll ask you first, what does this chemoimmuno-neoadjuvant approach, what impact does that have on radiation in this setting? Does it mean we're not going to use it anymore? Does it mean it's going to be reserved for patients who are not operable? Or is it still something we can throw into the mix and maybe we need to be adding radiation into what we're doing after chemoimmuno?
So, I mean, I think there's a number of issues there. And you and I in our MDT are learning much like, the rest of the country and the rest of the world in this regard. So up front, there are two questions. One is, does the surgeon think the disease is resectable? And then the other question, before you get out your IO and shove a needle in their arm, is the patient operable? Because there are some patients where you and I look in the MDT and the surgeon's, happy that this is resectable disease, but then takes a look at the patient in the clinic and due to their comorbidities, it's not going to be the right thing for them. So those are the two key things for me to send them down that route. And then, hopefully they will never need me. The risk is, though, that either the disease at the time of surgery doesn't become resectable, or the patient, along the way becomes inoperable because they have really bad tox or some intercurrent comorbidity that goes on. And then we're left with a kind of potentially suboptimal sequential chemo IO RAD type option, which isn't really evidence-based, although we know in Checkmate 816, you know, many patients didn't get the full, you know, sacked up front and surgery.
And we've had our own patients who've done that, who unexpectedly weren't surgical candidates, even though on day one we thought they were. Yeah,
absolutely. And I've certainly had one, I think it's a Professor Popat patient rather than a Tom Newsom-Davis patient, who actually had an R2 resection. They just couldn't get it all out. So, you know, this is where you know, we're really trying to define this resectability up front. And it is very difficult, which is why the important piece of work that Corinne's been involved with at European level to try and define this resectability, I think is going to be really important.
That's an excellent segue, and you're right, it was Professor Popat patient, because we don't do R2 resections at Chelsea Westminster. Corinne, tell me about that, because for those of us lucky enough to be at BTOG in Belfast, we heard a little bit about, I don't think they've been formally published yet, but these guidelines about resectability. Tell us a little bit about that. This is a consensus statement, is that correct?
Yes, so the work that we've done with the URTC in collaboration with quite a number of other societies, so including the European Respiratory Society, Surgical Society, etc., is a multidisciplinary consensual definition of resectable stage 3 non-small cell lung cancer. And it's important to say that this is meant to be a consensus to be used in clinical trials, not in clinical practice. I mean, if people decide to use it in their clinical practice, then that's up to them. But that is the aim of the work, right? Because we wanted to have, going forward for future trials, to have a definition. But what's really important in this work is that the patients should be considered to be medically operable upfront. And I think that's where the concern is, as we've just discussed. When you asked the question to Fiona, you mentioned the word potentially resectable, and that's where the danger is. There may be some patients who are very borderline or not, or even not operable at all, and we had discussions around that at ESTRO, who will be offered chemo-IO, and then may not be able at all to be operated on for technical reasons, or, as Fiona mentioned, will end up having an operation and then we'll have an R1 or R2 resection. And given what we've learned recently from a long-out trial and the impact of post-op radiotherapy on the heart particularly, I think we have to be very cautious there. And something that we have discussed, haven't we, Fiona, time and time again, is that radiotherapy will not mop up the disease that is left behind. It is potentially a treatment that could be detrimental, so we have to be very careful there.
And just expand a little bit about on that lung art data and the cardiac toxicity, because it's a really important part. So could you just summarize for people who aren't familiar with the headline data on lung art, what it showed and what it didn't show?
Yeah, so lung art was a study comparing post-op radiotherapy in patients with complete resection, so R0 resection in stage 3 non-small cell lung cancer, versus no post-op radiotherapy. So post-op radiotherapy reduced the risk of local recurrence. However, there was no significant difference in PFS or overall survival. The primary endpoint of the study was PFS. And there was almost a threefold increase in the risk of cardiopulmonary deaths with post-op radiotherapy. So it's a really an important message, and it's in line with what we've learned from RTOG 0617 that Fiona mentioned earlier on. With the high dose of radiation, again, there were more, there were more deaths, and subsequent analysis found that the dose to the heart is potentially responsible for that, as well as the dose to, the blood pool causing lymphopenia.
How relevant is that result still, given the new techniques you mentioned, the fact that you are better now at avoiding or limiting doses to the heart? I mean, lung art still stands, but is there a time to review that, or is post-operative radiation really dead as of the lung art? results?
I mean, so that it was done for patients who had R0 resection, who at the time of surgery were found to have pathologically confirmed N2 nodes. So it didn't include N1 nodes.
Yep.
And so largely we moved away from doing it because it was a negative study and we know that it adds toxicity, but we're still in the situation you couldn't put patients into that study if there was an R1 resection margin because it was considered standard of care. And therefore we're in the situation now that if we get an R1 resection margin, because there's potentially microscopic disease, left behind, we do need to consider it because those patients weren't in the study.
Yeah.
But the toxicity is going to still hold. I mean, yes, hopefully centres are doing more and more, closer to 100% IMRT rather than 3 fields. There may have been a bit of further advancement in techniques since when lung art began recruiting, but in general I don't think we think we're going to see an awful lot of lower toxicity because of the vast swathe of the mediastinum that you include. So it basically means what we don't like is carrying that mop, as Corinne says, which we don't like R1 resection margins. R2 is a bit different because R2, we tend to restage, look at it, and then it's almost starting again from square one and saying, well, do we need to do concurrent, depending on the patient. But it's these R1s where we really are left with no option other than to consider post-op radiotherapy lung art like, but in the R1 setting. And we know that comes with this toxicity and the 3-fold increase in cardiopulmonary toxicity.
Okay, that's really helpful. We're going to move away from surgery and we're going to move towards I guess what people might see now as a more conventional chemoradiotherapy. It's been decided in the MDT the patient is either not operable or not resectable, or perhaps both. But it is stage 3 disease. We're going to go down that radical route. Fiona gets very excited. This is a chemo-rad patient. Our surgeons get very disappointed and they switch off their Teams link. What do we know about? Well, I guess what's new in this, and particularly, are there any changes in the radiotherapy aspect, and what changes have there been in terms of immunotherapy and timings of immunotherapy? Maybe, Corinne, if you want to do that one.
So I'll start with what's changed in terms of radiotherapy, and I think Fiona can talk about the current administration of immunotherapy because she was the discussant of the Pacific 2 trial at ELCC. So just coming back to the theme of the heart, I think that's one of the really big priority at the moment in terms of research, is to try to understand how, what region of the heart we should be avoiding in order to reduce toxicity and in order to improve survival. So at the moment, there are a number of teams around the world working on this theme, and at the Christie, we have quite an innovative study where we have implemented a dose limit to the base of the heart based on research we've done over the last decade here, and we're using a pragmatic design, so-called sort of rapid learning design, to demonstrate the impact on survival of the introduction of this new dose limit to the base of the heart. So this is initially only done at the Christie, but we're very much hoping that this new methodology could be rolled out elsewhere in the UK in order to demonstrate an impact of a change in radiotherapy technique on patients' outcome. So that's one of the big change. I've mentioned protons as well. So we have discussions at the moment at national level to perform a study of protons versus photons in stage 3 non-small cell lung cancer in order to try again to reduce toxicity and improve survival.
And how do you measure that toxicity? Are you just looking at dose, the dose the heart is exposed to, or are you also looking later on at ventricular function and so on?
Yeah, so that's a good question. So we don't understand fully the mechanism of cardiac toxicity. So again, that's part of the research that has been done at the Christie. So that was led by Catherine Banfield, one of my colleagues, to understand with CT angiogram and ECGs and other investigations the impact of radiation on the heart. And we came to the conclusion 2 or 3 years ago, that the base of the heart, so the top bit of the heart where the conduction system is and where the origin of the coronary arteries is the area that should be avoided with regards to radiotherapy planning. So that's what we're focusing on right now.
The base of the heart higher up, in other words, not
yeah,
the,
that's right.
not the apex.
It makes no sense,
Yeah.
but it's so the base of the heart
Yeah.
is actually the top of the heart anatomically. I know it's counterintuitive.
That's about the limit of my cardiac knowledge, by the way, but that's helpful. Okay. That's really interesting. Fee, what about the timing of immunotherapy? What did you cover in your ELCC discussant?
Yeah, so as you know, Pacific, the original, now with its out to 5-year overall survival data advantage, has become standard of care. So patients are getting concurrent chemoradiation and then going on to a year's worth of adjuvant durvalumab. So the study that was presented for the first time at ELCC was Pacific 2, which is was basically bringing the durvalumab earlier in the treatment pathway. So rather than concurrent chemo-rad followed by adjuvant durva, you were getting durva from day one. So you were having concurrent chemo-IO radiation and then followed by, durva in a kind of consolidation or maintenance setting afterwards.
And that wasn't done in original Pacific, presumably because there was some concerns about toxicity. Was that the...
Well, yeah, but also the whole design of the original Pacific is you didn't get entered into the study and you didn't get randomized till after the chemo-rad. They didn't collect the chemo-rad data. You had to have demonstrated non-progression to even be eligible for the study, and then
so you'd already selected the, if I may say, the better patients because they had already responded and not progressed.
So that's one of the interesting points. We don't have the original denominator, but there was a big potential assumption that many patients had been weeded out. So the kind of rationale behind Pacific 2 was to say, to get more patients as far as benefiting from IO, let's start it earlier. And then because they're getting the IO earlier, there'll be more patients overall that benefit from IO, and we'll avoid the ones that were going to progress between chemo-rad and IO. And what was one of the interesting things in the study is basically both arms, whether they had, and the standard arm of PAC2 had no durva because it was started before PAC Pacific read out. So it was chemo-IO radiation followed by IO versus chemo-rad, old-fashioned pre-Pacific. And what they demonstrated was that this kind of progression, like straight after chemo-rad, didn't happen. So even in the standard arm that had chemo-rad, none of them seemed to progress, which was quite surprising. So then if you're not preventing progression, are you only adding toxicity, which kind of seemed to be the case? So by bringing the immunotherapy forward, there wasn't any additional PFS or OS benefits seen in the trial, but there was quite a bit of extra toxicity leading to discontinuation.
And what was that tox?
Just in the imbalance. So the arms were a bit imbalanced when you look at some of the baseline characteristics. So it was stacked against the investigational arm. So there was a higher proportion in the investigation arm of squames. There was a higher portion of PD-L1 negative, and there was a higher portion of EGFR unknowns.
Right.
So potentially EGFR positives, I guess.
Who we'd expect to do less well with the addition of immunotherapy.
Yeah.
Less benefit.
Also, there was quite a big difference in the number of T4 tumours. Now, we used to people reporting stage as baseline, but we don't normally see the TNM kind of breakdown, and lots of T4 tumours, which when you then look at the toxicity, the main toxicities differentiating the two were infections, higher rate of infections in the investigational arm, but also a small but significant, it was between 2 and 3% of like fatal hemoptysis.
Okay.
So, it's difficult to tease out, but the overall message was in that population, albeit the deck of cards were slightly stacked against them, you're seeing increased toxicity by bringing the IO earlier. But anyway, this whole kind of progression thing didn't really exist in either arm.
So more is not necessarily better. We stay with our specific regimen.
Yeah, we've also had the checkmate 73L trial that we haven't seen the results of yet.
No.
But they've done a press release, and that was similar, but it was checkmate, so it was Ipi-Nivo,
Yeah.
bringing that earlier up. So the
Also
press
didn't seem to
releases
benefit.
didn't seem to benefit, but
Yeah.
we don't have the results. And the other thing that we're going to get in 2-3 weeks, when's ASCO? 2 or 3 weeks time?
Just over a week's time.
Just over a week's time is Laura, which also
Yes.
will change things, because at the moment, based on the EGFR data, we tend not to offer them the durvalumab, but we can't offer them any osimertinib a la Adora Flora.
Yes.
Because we've been missing this aura piece of data. And again, I think the press release is positive, but we are yet to see the data.
So that's osimertinib in locally advanced disease.
Yeah.
Okay, thank you very much. We're gonna do some crystal ball gazing. Corinne, we're gonna move forward to 2030. Gosh, that's only 6 years away.
Retirement.
Yeah.
Well, now you're talking about retirement.
Yeah.
Yes.
So you'll have your feet up somewhere on the beach. Fee and I will still be slogging away in clinic. Will we still be giving chemotherapy with radiation in unresectable disease in 2030? Or do you think we can probably begin to weed this out because we'll have good enough immunos that we can get rid of the awful platinum and other drugs?
Well, that is an excellent question, and
isn't it?
we're working very hard on trying to get rid of the chemotherapy. So you mentioned at the start of the podcast the Concord trial. So Alistair Greystoke and I are leading this phase 1 platforms investigating concurrent DNA damage repair inhibitors together with radiotherapy. So at the moment, that is in the context of sequential chemoradiotherapy or radiotherapy alone. But, that could, potentially be a treatment of the future. We may not need to add chemotherapy to radiotherapy. Perhaps it will be replaced by one of these agents in combination, of course, with immunotherapy. So in the Concord platform, we have 4 experimental arms, and 2 of them include immunotherapy as well as the DNA damage repair inhibitor.
Okay, that'd be very exciting. Put the
because let's not
oncologist out of a
forget,
job.
Yeah, absolutely. And let's not forget the reality of our practice. The vast majority of our patients are elderly with major comorbidities, and if we could spare them the side effects of chemotherapy and also make more patients sort of suitable for combination treatment, I think that would, certainly make a massive difference.
I think you're absolutely right. Platinum chemotherapy it's a tough gig, and it's tough if your performance status isn't excellent and if you're a little bit older. And we should try to make sure our treatments are available to everyone, not just a select few. So, last question, Fiona. Monitoring of responses and outcomes. I mean, we tend to do that with scans, and we love a Kaplan-Meier curve. Any other approaches that we might look at? I guess really thinking about EPROMs. Everyone loves an EPROM. Could you explain what an EPROM is? And
So
do you think they have a role?
I really am the wrong one of the two of us to answer this, Tom.
Okay, Corinne.
Bearing in mind who's developed this. So I will hand this over to Corinne.
Excellent.
Right. Well, I always, if I have an opportunity to talk about EPROMs, I always will. So,
Super.
Yes, I think that's, we're talking about the future in 2030. I would hope that by 2030, all of our patients will be monitored that way, because EPROMs really gives, patients a voice. So, we all evaluate the side effects of our treatments in clinic. It's done by doctors, by nurses, but we now have a lot of evidence that we tend to under-evaluate the severity of the side effects of our treatment. But also there are many questions we never ask. So we never ask questions about anxiety and depression, for example. Or we rarely ask systematically, because many of us have busy clinics and we don't really have time to do that, and the impact on quality of life. So if you have an EPROM questionnaire that will include a number of questions about patient symptoms, and then VQ5D, for example, that includes 5 questions on patient's quality of life, then you will have that available prior to a consultation. So at the Christie, we're very proud that we have a an EPROM initiative on a trust basis. So certainly for all of our patients with lung cancer, 2 or 3 days before a consultation, they receive a link. They can fill in this EPROM, which is then uploaded automatically into the electronic patient record. So a nurse or a doctor seeing patients can see what the symptoms are, what the quality of life is, and also see whether there are any changes from one consultation to another, which is a major advantage if, for example, someone is not seen by the same person from one clinic to another. We also have now level 1 evidence from randomized controlled trials that using EPROM in the follow-up of patients improves quality of life, reduces the number of admissions, and importantly, also improves survival. So we have at least 2 randomized trials showing that.
I think it's brilliant. I mean, I'd love to have that. And we see in our trials patients are quite good at getting patient-reported outcomes, but I think we have to have that in routine clinic. I agree completely that people often don't tell us what's going on. Difficult in a 5-minute consultation. That is extremely helpful. I think we will leave it there. Thank you both very much for joining us and for updating us on events. Thank you to our audience for listening. And if you did want to, for example, catch that update on the resectability guidelines, if you were at BTOG 24, that is available as a catch-up on the BTOG website. And if you weren't there, but you're a member, you can still catch up with it, but you have to wait another 5 months to do so. Thank you very much for listening, and to my 2 fantastic guests.
Thank you, Tom.
Thank you for listening and joining us on this podcast. For more information on BTOG, including education events and how to become a member, you can visit us at www.btog.org.